All right, looks like we are live. Welcome everyone to First Friday with APHPT, the APHPT Happy Hour. I am joined by my good friend and colleague, Megan Doyle, an APHPT member and an occupational therapist.
Oh.
Megan, please, I don't want to, you're an impressive person to try to introduce, so I'm just going to let you introduce yourself and share a little bit about kind of who you are, where you're at, and what you do.
Oh, I appreciate that so much, Erin. And it's funny because I do a lot of these things now and people read, bios, and then I kind of segue and I'm like, no, I need you to know that you can do this too.
Yeah.
So that would be a message that I do is that, so I am an occupational therapist. I have actually practiced in a multitude of different settings. I've done a little bit of everything just because my husband was true active duty Army. Now he's National Guard here in Boise, Idaho. So that's where I am. So by nature, it's been great in my career. I've gotten to do true acute care. I've done outpatient, anything in outpatient you could possibly think of. I've done neuro, ortho, post-concussion management. I've even done on work site injury prevention, long-term care. But right now, I'm for the past so many years, I've been in more of an inpatient, so true acute rehab, and then subacute rehab or skilled nursing level. And I just have always been super passionate about health and wellness and also mental and behavioral health, which is such a huge part of occupational therapy scope. But we know now that that really needs to be part of everyone's scope, as it should be for our patients, and pain. So I've done an certification as a therapeutic pain specialist. And then I went on to do the full fellowship in pain sciences through Evidence in Motion, and became a member of APHPT, and I'm a cert grad from 2018, and always wanted to marry all of those different things. And so, I'm so excited that Erin wanted me to talk tonight about my scholarly project that got published very recently, finally, because I only started working on it, in 2019, 2020. That's how these things go. And a little thing called the pandemic happened during that time. That probably had something to do with it. But trying to take all this experience and try to be a leader in this space and really think, how can we move health, wellness, promotion, but especially the treatment of pain from a holistic standpoint upstream. So that's really what this paper is about.
Yeah, absolutely. I think I titled the teaser of this First Friday, like getting upstream in a downstream setting.
Yeah.
And I feel like, as we kind of talked a little bit before hopping on live, this paper is a really, really cool example of that. And, just how important, as you mentioned in the paper, P&E approaches to, managing pain. And remind me exactly what P&E stands for.
I was about to say.
Pain neuroscience education, right?
We need to give everybody a definition. So pain neuroscience education. Sometimes it's referred to as pain physiology or pain science education. It's really educating somebody about how does pain work from a true biopsychosocial perspective, but just the physiology. And it's really about helping people understand that, yes, there's these biological aspects, but we have to talk about the nervous system. How does that function? How do our thoughts, feelings, emotions, the social components? So it's really just educating people on how pain works.
Yeah, absolutely. And so, P&E, as you mentioned in the paper, was originated, or, I guess maybe introduced and mostly studied in therapist populations, but introducing it to other colleagues and making it a true multidisciplinary approach is so important. And perhaps no better place to introduce it than a setting, where pain management is such a big focus, such as in the hospital or inpatient rehab settings. But I guess before we get too much into that, I just want to start more broad and have you sort of summarize what was the inspiration for even delving into this, for coming up with this idea in the first place to research this topic, and maybe just a high level summary of, what your objectives were with the study.
Yeah, absolutely. So this is where again, sharing my background that I did work in some more of these other settings. So working more in outpatient, that's when I was actually first introduced to pain neuroscience education, first did the therapeutic pain specialist certification. So it is a concept that's been really focused more on with chronic pain, persistent pain states, helping to treat that, and more in these outpatient clinic settings. And then, what is it? The necessity of, I'm forgetting the quote right now, Erin. Trying to think. I got placed into this inpatient rehab setting, which full disclosure, I still am like an outpatient person. I will always be a person. But when we first came to Boise, beggars can't be choosers. And there really wasn't an outpatient position available. I started working for my current health system in this inpatient rehab role. And that was around the same time that I took on the pain fellowship. I'm trying to talk about the quote about the necessity is the mother of all
Invention.
Thank
Yeah.
you. I apologize. Tongue-tied after a long day at work.
No worries.
Regroup here a little bit. But that's been my story with this, because I had this massive aha moment being in the setting. So here I am, desperate to incorporate pain science, and I'm getting into the fellowship, and I'm starting to learn more about what are these different risk factors that genetically or neurophysiologically, what are the things that can contribute to a risk for somebody in a hospital setting, somebody that's had a surgery, go on to develop chronic pain after that acute initial event. And then I was like, oh my gosh, you are in the perfect setting to address this. You're in this setting where you have this interdisciplinary team already. You're in the setting where you have therapists that are interacting with these people, but then also, nurses who are helping to make this choice between, do we do medications? Do we do, different non-pharmacological, and then also the interaction piece. And that's what I had shared with Erin before we got started. I really want to get into tonight, because I don't think that's as clear in this paper as you would like it to be. There's only so much room. But yeah, so it was just getting really excited about this thought of, hey, if we're moving upstream, if I'm already in this acute care inpatient rehab setting, and I'm seeing folks, true like acute post-op pain or multi-trauma, or even people that are having acute on persistent pain, this is a beautiful setting to start addressing this, because we can really nip a lot of this risk in the bud. I get asked a lot, is it truly possible to reduce all risk of pain, acute pain, unfortunately transitioning to chronic pain? Well, the answer unfortunately is no. You'd have to go into like true epigenetics and like do brain scans on everyone. There's really good research for that. But just this idea that we could be doing so much more in these settings. And that's when the idea for this was born. And obviously I got really excited about it.
Clearly. And I forgot to say too, congrats on making it reach publication. That's amazing. Yeah. And I can't imagine the amount of effort and persistence it took, especially probably working through a pandemic, and how much that probably shaked up the process of things. But really, really cool to see it, reach publication. And not anything that I know anything about. I've never done formal research in that way, but I imagine it is a grueling process. So with that sort of introduction, trying to optimize, I guess really just introduce evidence-based practice into the inpatient rehab setting, and in sort of like what seems like a boots on the ground sort of fashion, not like policy driven. This is really like peer-to-peer mentoring, something that to me feels potentially very replicable and very practical in terms of its approach. So maybe where would you like to go next? Would you like to talk a little bit about what the intervention kind of was that you were doing in terms of the education for the nurses that you were providing? And then maybe we can from there talk about maybe the method to the madness of the greater why that is so impactful, and talk about the interaction aspect that you mentioned.
Yeah, absolutely. I think that's a great place to start because I
Okay.
just shared, here's like the big idea. And this kind of took on a twofold thing too. I did happen to come on to this inpatient setting. Sometimes it is about the right place, right time. And I think a little bit of that, I had the support. So again, trying to find the people that support you, find your team, find your tribe. I had a lot of support from my OT supervisor at the time. She really believed in this and this idea. And also in 2018, that was a year where different hospital settings like CARF and CMS and Joint Commission really put their foot down and said, we need better guidelines for addressing the opioid crisis. We stipulate that you must be providing non-pharmacological treatment options for patients. You have to document that. You have to show that. So I was also a benefit to them too, because it's like, here's Megan, hot to trot on this. Oh, we need to address this. Oh, great. Here's somebody that wants to help us do it. So that did help to get this kind of moved along.
Yeah.
So that first iteration of all this was, okay, well, how do we promote more non-pharmacological treatments for our patients? Well, I thought, the therapy staff, and I've done separate training with them too, but the nurses, I was like, man, that's an area we got to really hit hard because they're the ones at the end of the day, they can really guide those choices. And they can guide, if they just go in and is the interaction just, oh, here's your pain meds, that's it. Or can they really talk to somebody, work on a plan, focus on these different other options, really have a conversation and really develop a relationship with their patient. So the first iteration of this, we created the pain control comfort menu, which is detailed in the paper. And it has all different options. And I wish I had asked for I had wanted the picture of it to be in the paper and it didn't get in there. But if you were to see it, you would see there's actually two sections to it for a reason. So there's a more nursing driven section, and then there's actually a therapist driven section, recognizing that nursing is only going to have so much time. Therapy is going to have more time, and we have a lot of different disciplines that it can address these things. We also have, for instance, recreational therapy too. Recreational therapy really can help with relaxation techniques, for instance, or other things. So the menu drove the person to say, oh, I didn't realize, I could do this for my pain. What more could I do here? And you actually are supposed to have a paper copy where the person can actually mark their choices. And there's laminated copies in every patient's room and all these different things. And the nurses learned to go through it with them when they were orienting them to the floor at admission, for instance. And then the P&E part really comes in. I was able to create a PowerPoint presentation that was roughly 30 minutes long, where I would actually sit with the nursing staff during their new hire orientation and take them through the basics, like the basics of, this is what we thought our old school model of pain was, more biomedical driven. This is the new model. I taught them Louis Gilbert's mature organism model, which is one of the best ways to introduce the biopsychosocial model. Talked about why pain and tissue damage are not equal. And then I really hit hard all of the research on the effects of emotional support for pain, that therapeutic alliance concept, and really creating safety. So much great research to show that if we're compassionate, we have that therapeutic alliance, that therapeutic relationship, that our patients that we're working with will absolutely be in safety, and they'll start to produce their own endorphins. And it takes mere seconds, even moments. So that was a huge thing I wanted to reiterate with the nurses. And that really kind of comes around to this whole piece of emphasizing the emotional, compassionate part and talking to them about, well, what are some of these risk factors for patients to transition potentially from acute pain postoperatively, maybe to persistent pain. If we're addressing this now, we can really make a big difference. It's about, making unknowns known. So much as, we talk about medical things, but patients don't know about how this is normal, this is not, and not saying it in a patronizing way, but doing it in a really compassionate way. If somebody doesn't know what weight bearing is tolerated on a post-operative fractured leg, why do we expect them to know what that is? So the nurse's role of really decreasing that threat value as well and helping decrease that protection. So that was all where this all started. And then, the next level of all these different interventions was, first of all, trying to reiterate the training, making sure as many nurses as possible had that training. But I kind of hit on already the piece I was saying, Erin, I wanted to hit on, which is, this emotional, spiritual support, guided imagery, relaxation techniques, therapeutic present touch. What's cool is that that's not arbitrary language. Those are actual selections in the drop-down menus when you go to chart pain. So those are actually listed for all of us to document, which is very cool. And I would hope more health systems have that.
Very cool.
But then another component to that was I did have nurses who approached me and they really did want to learn how to do more techniques. They said, can you teach me more about deep breathing and why is that beneficial? Or how could I coach a patient through deep breathing? Or can you teach me about guided imagery and how I might be able to coach a patient through that? And I was trying to be mindful of timing for them. I mean, I even went so far as to create, paper handouts that they could be able to give to patients, just recognizing nurses only do have so much time and they're strapped with having to chart so much, unfortunately. So it was just trying to find the time and really identify the nurses too that wanted to take it to that next level and learn some more of these techniques to really hit hard the psycho and emotional components for the patient's pain experience, because all the research tells us those are the areas that are going to contribute to that transition from acute to persistent pain the most. And those are the areas that we can hit the best, I think, in these inpatient acute settings.
I feel like that's a big point. Can you repeat that? What are the two areas that are most likely to contribute to persistent pain the most?
I would say, social is another piece too, but psychological and emotional.
Okay.
So psychological and emotional, it's all about that threat perception and that elevated stress and having, increased fear avoidance. And then the social piece comes in, but with the biopsychosocial, because, that's family and partners and that. But if you really think about it, at the end of the day, when somebody's hospitalized, the staff really becomes that other social piece. And so if they are actually interacting with them in a therapeutic and supportive and compassionate and empathetic manner, that's that other piece, because that's going to keep stress low. That's going to keep stress hormones, cortisol lower. That's going to release, all these endorphins and other lovely hormones like serotonin and oxytocin and dopamine. And all of that has been shown to downregulate, pain. So that's a huge part of it. And just getting the nursing staff to recognize that that was a part of their role when they were having those interactions.
Yeah. I think that's super important too. And it makes a ton of sense. The fact that, the psychological and emotional aspect is maybe the biggest driver of transition from acute to persistent pain, and the influence that we as clinicians, particularly maybe nursing staff who are interacting with patients, perhaps at one of their most vulnerable times, when they're in a hospital and maybe a very, challenging state, to be very empathetic, very comforting, reduce the threat level, release all those hormones you're talking about, and even be in a setting where, perhaps patients are in real time hooked up to machines that are reading vitals. And so you can be working on things like deep breathing, and maybe you can't measure their hormone levels, but you can say, look, after that, 5 minutes of deep breathing we did, look how your blood pressure's changed, look how your heart rate's changed, how are you feeling now? And like try to have that sort of physiological response objectively noted for the patient to maybe increase that buy-in, which is something I sometimes try to do in the outpatient setting, but might be really even really cool in an inpatient setting where those vitals are kind of being monitored naturally anyway. So that's one thought that I had.
No, that's a fantastic thought. And I've done it. I've done that. I'm like, oh my gosh, look here, I can do biofeedback in real time, because
biofeedback.
And the other piece that I didn't get to talk about yet either, and this is where, as an occupational therapist, my scope and my mindset being, how do I help somebody achieve self-management and self-efficacy? So that is that ability to do just fight, So pain self-efficacy, there's several definitions, but at the end of the day, it's about what can you do despite pain. And so that's another piece here, because you can take a passive approach to post-operative acute pain or your recovery process in rehab. But that rehab mindset and getting nursing and therapies on the same page, I think therapies, we operate more from that space. When I had conversations with my nursing colleagues when I was doing this training, they were really open with me and they recognized, wow, you know what? Our nursing paradigm is the opposite of this. Our nursing paradigm is, they feel, I'm not speaking for all nurses, but this just really trying to do a deep dive into why this might be a barrier. A lot of my nursing colleagues said, we really feel that it's our responsibility to take our patients' pain away. And that is a more passive approach versus how do we create more of this independence with self-management and the self-efficacy. Pain self-efficacy is talked about, and self-management is talked about a ton in chronic persistent pain conditions. But there's such value in promoting that in an acute pain state.
Right.
Because again, going to the fear avoidance model. So the fear avoidance model, really is that demonstrator of, well, what are some of those other risk factors of going into chronic pain? If you are fearful to move, if the pain is too much to overcome, if pain equals harm, if you feel like you want to stay in bed or take more of that passive approach, versus we know as the therapists in these settings are, no, we want to help you move. What are your goals? What are your functional goals? What do you want to be able to do independently again? And to get the rehab nurses mindset around that, not just they were on board with that from those perspectives, but then also increasing the independence for patients with using a relaxation technique or using other things like breath work for themselves. So they were increasing that self-management independence, which we know supports our overall mental behavioral health when we can do that. But then also the bathing, dressing, I had questionnaires that I used to measure patients' belief in self-efficacy to see if over time they would feel like they were able to do more, not just from a recovery standpoint, but we know post-operatively, you're still going to have some pain. But what are you able to do with it? Or is it going to be at a point now where you're like, yeah, I'm still kind of feeling my hip, but it's not preventing me from getting up and going to the bathroom. It's not preventing me now from, starting to get back out in life and start to get to do some more of these goals. So that self-efficacy piece, if that again is addressed in this acute pain state or this inpatient setting, more upstream, that's part of that psycho-emotional piece that's going to have a huge effect downstream. And so just trying to help the nursing staff. And that's where, as an occupational therapist, I thought that was a great paradigm for us to meet with, because that was the paradigm that I was operating from. And what's really cool is that there's so much out there to show that paradigm in the treatment of any pain, both chronic and acute, is best practice. So trying to help the nursing staff recognize that was the paradigm that we needed to try to operate from. But it was they had to change their paradigm, and not in a bad way. Most of the nursing staff really said, you know what, I never really thought about it this way, but this is what I want. I want for them now to be more independent with some of these different strategies that they can do for themselves.
Yeah, that's I think that's so awesome and so fascinating, because I think, that paradigm that maybe the nurses find themselves operating in, I don't think is very different from where a lot of therapists would say they feel they are operating in, very much like a symptom reduction, pain reduction sort of focus. And even myself kind of find myself in that mindset. It's hard to get out of. And, in some ways it feels good to be able to ask a simple question of like, what's your pain level, and see that reduced through just, the patient self-reporting it. But what is that impact on their beliefs and their behaviors is, I think, really the underlying thing that's so much more important. And one takeaway I had from your paper that I really liked was just and I just pulled it up here, was just the 2 questions you asked as part of your outcomes regarding basically what I would I guess describe as pain self-management or self-efficacy. But how confident do you feel in understanding and managing your pain? Asking that to the patient. And then how confident are you in being able to treat your pain in ways other than pain medication? I think a lot of times in my own, reflecting in my own practice, I'll ask about whether or not they're taking medications for pain and what those medications are. And I probably, will, maybe this sounds probably more negative than I mean it to, but lecture the patient on why some of those things may not be all that helpful, especially long term. And we want to, be mindful of any side effects that could be happening, and only take them as needed. And they're not meant to be long-term solutions, especially if they're opioid sort of medications. But I think the way that the paper phrased those questions is so much more focused on self-efficacy and less about like the pain itself, if that makes sense. And sort of, I guess it still is very much about how that person's managing it, but how they're able to manage it themselves. And so anyway, random aside, but something that I read that and I was like, those would be perfect interview questions to ask a patient, even in an outpatient setting. And I feel like I could get a lot of information from that. And seeing that response change over time, as you did in your paper, from the pre to post intervention, would be something that I think would be a helpful metric to track in a variety of settings.
I really appreciate you bringing that up, because you're right. When I wrote those questions, I did it very deliberately because I wanted to capture the non-pharmacological piece. However, I will tell you, the pendulum in some ways has swung too far when it comes to the opioid crisis. I have worked now with so many individuals who either they've been on opioids responsibly and it's helped them.
Yeah.
And, you got to think about it between a rock and a hard place. So, yes, is there really great research to show that ultimately it will benefit to hopefully be off of them? Yes, and that can happen. But if we go into it, they already know, they're already feeling shame. They're already dealing with shame from physicians. So I always come in and I just approach it. And the importance of those questions too are they really fall in line with those core motivational interviewing tenets. Try to use those open-ended questions when you're interviewing your patient about their pain. So I understand that you may be taking some pain medications. I want to make sure that you feel like those have been beneficial for you. That's a conversation we can have. I would really love to know, what are some other things that have been helpful for your pain? And try to have that super open-ended. It's going to give you a lot of information. But the other part about that too is you're not denying their lived experience. So if somebody is having, and I tell people too, I'm like, I'm not here. It is not my role to tell you that medications do not have their place. If you have a goal of reducing your pain medication use, that's a great conversation for us to have. I'd love to support you in other ways to be able to treat your pain or be able to participate more in your activities despite having any pain or symptoms you have. What are your thoughts on that? Or what are some things that you've done that have worked with you in the past? So you have that open-ended dialogue and you bring in the person's lived experience and you do it in a very non-patronizing way. Because I will tell you, I've also worked with people who come into inpatient right now and they have a surgery and they are so afraid of taking any opiate after their surgery. And it's just this whole dynamic and so there's so much shame and so many issues that way because people are so aware. So you get on both sides. You see people that have been taking it for a long time, but are doing it responsibly, but there's issues around that. And then you see people that now are trying to, maybe taking it for the first time after surgery, but they're so, it's just so many different dynamics. So approaching it in a lived experience way and giving that person that opportunity to share their lived experience and what they feel works for them. And what's really cool about that is that it opens the door. I've had so many people, I've educated them on a relaxation technique, let's say, and they're like, oh, I used to do this when I was younger. I used to do progressive muscle relaxation. I never would have known that this is something that would help me now after the surgery.
Yeah.
And it's a skill that they already have, which is even better.
Yeah.
Such a cool moment for them to bring that back. And they're like, I just never would have put these pieces together. And that is what drives me. Because in that
Yeah.
moment, heart breaks a little bit, but then at the same time, I get excited because I'm like, wow, this tells us there's such an untapped potential. If the providers or whoever is working with somebody even just has that knowledge and can and help them make that connection, it's like that just needs to be common knowledge. That's the whole point of that too, because then people will recognize how that's beneficial to treat their post-operative pain or any type of pain.
Absolutely. I think that was so beautifully said, and gives me a good amount of reflection for my own clinical practice and ways that, I can improve. So appreciate you sharing all that and sharing it in a way even that I think I'm sure when I can see how when you engage in those discussions in that way with patients, it's very inviting, it's very non-threatening. And I could also see how when you're teaching it to clinicians, such as the nursing staff in this study, the way that you teach it is very non-threatening and very, non-shaming of current clinical practice, even though it might not be what is reflective of best practice. So I can tell you've practiced this quite a bit, and you're very skillful at it. So awesome job, Megan. Cool. Well, I think maybe one aspect I'm not sure if we've given enough, I guess, credit to or attention to yet is that like interaction as intervention piece that we've mentioned a little bit, but if there's anything else you wanted to share about the importance of that, before we hopped on, you had mentioned it was something that you wanted to, a message that in a concept you really wanted to get across to the listeners about the importance of therapeutic alliance and how that really underpins a lot of what this study was all about. So I know, again, you've talked a little bit about it. I don't mean to be too redundant, but definitely wanted to open the floor for you to share more about that or anything else that you wanted to share with the listeners before we kind of wrap up.
Yeah, no, I appreciate that because we've hit on it some. And I mentioned again, I shared with the nursing staff, there's just such good research out there. A great name to know, plus it's a fun name to say, is Dr. Fabrizio Benedetti. He is an Italian neuroscientist and physician who in 2011 published a book called The Patient-Doctor Relationship, or I think it's the Patient's Brain, but I know it's from 2011. And he really did he focused all of his focus on why is it that, with this therapeutic alliance and the doctor-patient relationship, what's really happening on a neurochemical or neurophysiological level. And he showed, those therapeutic alliance components, the hope, compassion, empathy in those, even in a primary care setting, make a difference over time with, releasing those hormones that I mentioned. Oxytocin gets released. That's very much that social piece that gets released in the act of touch. And that's gotten lost. I mean, goodness knows that got lost in the pandemic. Don't touch people. So trying to bring that back. But the act of touch, that's the love hormone, it gets referred to sometimes. So touch can help bring on oxytocin, creating, serotonin, reduces anxiety, which would reduce and modulate pain. And then also, like I was mentioning, dopamine is important to understand because that's the reward hormone. It gets talked about, it's also the addiction hormone too. But if we're trying to get people, that's that self-efficacy piece, like educating them on that interaction. If they're feeling good, the nurse is even talking like, oh, wow, you did so great in therapy today. Tell me about it. That's that reward. That's a dopamine hit that's happening too. And then I mentioned, and this is where I want to insert polyvagal theory. So I had mentioned that I wanted to talk about that. So polyvagal theory, so much more is getting talked about, trauma-informed care. And I know we've had some really cool dives in this tribe. It's over a year ago now, I did the Body Keeps the Score in our book jam, and polyvagal theory is talked about a lot. It's this theory with the vagus nerve, which is really the conduit between the brainstem and the visceral organs. So it's really at the heart of what makes the true mind-body connection. And when we talk about things like Why is it that when our fear response kicks in, your heart rate's going to race, right? We talked about blood pressure and we talked about heart rate variability. Polyvagal theory starts to really get us to understand how we can have those stress responses change over time. It better understands the difference or the changes between the sympathetic and the parasympathetic nervous systems. So our breath, for instance, when we're inhaling, that's actually engaging the sympathetic nervous system. And when we're exhaling, it's actually engaging the parasympathetic nervous system. So it's this voluntary control that we have. And with polyvagal, it's important for things, unfortunately, like childhood trauma, for instance, or any type of trauma response, that sympathetic nervous system we know would therefore be more of a driver, could be over time, people being and feeling less safe. So polyvagal theory teaches us then, when life is good, when we can be more in that parasympathetic space, that's when people can feel like they can be calm and open and be very mindful, versus, unfortunately, if there's more of a trauma response over time and that sympathetic nervous system is more dominant, that's when we start to see more of the fight flight responses, or unfortunately freeze as well. This is where you see people that are more dissociated with depression over time. So why does that have anything to do with an acute care setting and pain? Well, you can have those trauma responses or feelings of unsafety and threat and protection after these pain experiences and around those pain experiences. So if you're focused on therapeutic alliance, the other piece of that would be if you are helping somebody feel safe, they're going to be able to start to come out of that sympathetic nervous system, that being more dominant, and be more in that relaxation state. And that has been shown, obviously, to affect variables like not just blood pressure and heart rate variability, but also the way that pain is processed and modulated because of that sympathetic nervous system response. So reducing that protection. So the thought would be, from a prevention standpoint, if you're recognizing that safety and creating that safety, and this is where breath work is so huge. So getting people to understand, hey, you can control your breath. This is why breathing has been shown, to down regulate things. You're calming that system down. If you're able to do that and help somebody feel truly safe in their environment and in their own bodies and in their own movement again, as they're recovering, that is going to decrease that pain and then also help reduce that risk of that acute to persistent pain transition. It's also better explaining why is it that some people, unfortunately, with trauma do go on to develop neuropathic pain states. Not all instances of fibromyalgia or chronic pain, for instance, are directly linked, but there's a high correlation between either childhood or other types of traumas and development of those persistent pain states in the future. And polyvagal therapy really explains a lot of that.
Wow. Super cool. So essentially, as clinicians, our interaction has, I guess, the ability to influence our physiology at that sort of very cellular level, that can almost, I guess, in a way, influences the most, the greatest risk factors for someone to transition from that acute to persistent pain state, like you had mentioned before. So I guess, again, really re-emphasizes how important interaction is. And I think to your point, and perhaps with COVID especially, and with the pandemic, the art of the physical exam and the art of interacting with patients, and as everything has gone so virtual, and we're doing this interview over Zoom, and so much of healthcare has kind of maybe transitioned towards electronic forms of delivery, still finding how to communicate empathy and true connection, both in a digital world, but as well as not losing that aspect in the physical connections either, is just so important. So how do you spell that phrase that you had said, is it polyvagal?
Yeah. And I wanted to add one piece to that too, because what we're really doing, so it's POLYVAGAL
Okay.
theory, and it's the vagus nerve.
Yeah.
Yeah, the polyvagal theory. And it's this hierarchy of these different kind of modes, and better explaining to why is it that, we may go to this one. And but really what we're doing with that therapeutic alliance, Aaron, and it has everything to do with those hormones being released. It's why we're social creatures. We were created, to feel good. Like when you have that social interaction, you get that oxytocin or you get serotonin released to reduce anxiety. We're also talking about co-regulation. So
Mm,
from a sensory processing and modulation standpoint, but sensory processing and modulation is huge in OT. It gets talked about a lot in pediatric populations, but this is why it's so important to address this in adults. We all need sensory modulation and regulation, but we can provide co-regulation. So for instance, if you're deep breathing with somebody, or you're touching them, or you're being compassionate with them, you're co-regulating with them. So you're getting your hormones going and released, and you're doing that in kind with them. And so it's this co-regulation part with that piece.
mm.
And that's where that social piece comes in the biopsychosocial model of pain. Somebody has that good social support. We know that helps so much with stress because it reduces stress chemical release and promotes those chemicals. And that's a huge part of that co-regulation part.
Got you. So in a way, like, we have an innate ability to detect someone else's, I guess, state of being, like how relaxed they are, how comfortable they are. And so as you portray, not only like fake it till you make it kind of way, but as you truly embody, like, I am relaxed, I'm deep breathing with you, and you have that shared experience, you can basically almost like transfer your physiology to the patient. um,
What somebody's looking for. So there these signs of safety. So from an evolutionary standpoint, that also explains why, if somebody's running out of the road, right, like the ankle versus the sprained ankle versus the bus story. So they're not going to feel that ankle because they need to get out of the way of the bus, but also they're literally trying to get to safety.
yeah,
And then they have their expressions of pain come on, because the thought from an evolutionary standpoint is, when somebody's in pain, part of those pain behaviors is they're alerting in the social network, hey, I'm
right,
in pain, come help me and come support me. And then
right.
that co-regulation happens, and those endorphins are released, and then that can start to calm that down. So that's that evolutionary perspective of that too.
Gosh, yeah. Super cool. Super cool. I feel like I could keep on talking with you about this for a while. I'm starting to nerd out, but it is already getting late. And we've already probably been chatting for over an hour, for the time that you hopped on and the little bit of time that we talked before we started recording. So greatly appreciate you being so generous with your time. Congrats again on this awesome paper. Encourage everyone to check it out. We'll definitely link it to our APHPT workplace when we post this recording, and link it in our Spotify description and all that kind of stuff where we'll post the podcast. Yeah, thank you so much, Megan. And hopefully, I'm sure we'll have you on another time. You're always doing pretty awesome stuff. So if nothing else, we'll have you on to talk about some water polo.
Yes, that would be awesome. I appreciate that. And yeah, I mean, this is, I just love the teaching aspect, doing the paper, trying to do different courses and try to get out there and do different things. But it's just exciting. Just if somebody takes one little piece of this and it changes their practice and they realize how important their interactions are, then I feel like at the end of the day, then I've made a difference.
Absolutely. Well, I'm sure you've already made a massive difference. It seems like in the health system you work at and with your colleagues based on the results of the paper. And I was curious too, it didn't seem like it in the paper, but is your group looking at any like long-term consistency in behavior change with the clinicians? Or like, is this something that your hospital system tracks on a continuous basis with the utilization of those comfort measures and basically patient exposure to them?
Yeah, I wish that we were doing more of that long term. I can say just from just kind of general chart review, and just speaking to the nurses, I do feel like there's an elevated understanding of the emotional component. I can say that with some certainty. I don't think that we really are at a point where we're tracking enough long term, but I do feel like that cultural aspect has shifted.
That's awesome. Okay, sweet. Well, thank you again. I will end our recording. Thank you everyone for listening, and please reach out to us at the APHBT. Our website is aphbt.org, and come join our tribe.